Right. So my name is Sanjoy Bhattacharya, and I work for the Department of History and the Center for Global Health Histories at the University of York. And one of my further pleasures is to work with colleagues from around the world through our WHO Collaborating Center for Global Health Histories. And today, I'm absolutely delighted to welcome all of you to the Global Health Histories Seminar number 110. We're very grateful to the Wellcome Trust for its support for the series, and of course, the WHO Regional Office for Europe, which is our main partner on this initiative. So today we have two wonderful speakers for you. We have Thomas Abraham, who's the former director of the Public Health Communication Program in the Journalism and Media Studies Center at the University of Hong Kong. Thomas is a consultant for the WHO and other international organizations on risk communication. So here we have a wonderful journalist who then became a first-class communicator, who has now written this terrific book, which we are honoring today through this event on polio eradication. I hope you will enjoy discussing with him what effective health communication is all about. Our second speaker is equally wonderful, a long-term collaborator, Professor David Heyman. I first got to know of David through the WHO archives. That is how historians get to know people. But he's currently the head of the Center on Global Health Security at Chatham House in London, and also Professor of Infectious Disease Epidemiology at the London School of Tropical Hygiene and Medicine. Previously, Professor Heymann was the WHO Assistant Director General for Health Security and Environment, and he was given the special responsibility. He was a representative of the WHO Director General, Margaret Chan, for polio eradication. So in David, we have a giant in global public health who has first-hand knowledge at all levels of the polio eradication program, and therefore I'm very much hoping that Thomas and David, who have been colleagues in the WHO together, will discuss and debate and allow us to discuss this amazing global health story with them. So without further ado, because you're here to listen to them, may I invite Thomas to present first. So they're going to speak very quickly for 20 minutes so that we have time for questions and answers as well. Thank you, Thomas.
Thank you very much, Sanjoy. It's a great pleasure, of course, to be here. And thank you very much for this invitation. And it's a great pleasure to speak alongside David Heyman as well. Sanjoy, both of you actually have had something to do with this book, though you bear no responsibility for the final product. I worked with David briefly in the WHO in 2009, at the time that he was head of the polio program, and that's really what got my curiosity about this going. Then when I started looking for ways to write about polio, I think one of the first books I came across was A History of Smallpox Eradication in India by one Professor Sanjoy Bhattacharya. And plus he had also done this lovely comparative study of smallpox and polio, and that came, I think, in the WHO bulletin some years ago. So I'm really indebted to both of you. It's a great privilege to be here, and to thank you all of you for being here as well. So, you know, I have a confession to make, right? At the back of my mind, I do feel that I'm a slight fraud standing in this academic audience. I'm not a historian, let alone a historian of medicine. I'm not an epidemiologist. I'm not a clinician. I'm none of the kind of people who normally write books about global health programs. So why did I do this? I'm a journalist by profession, and the methodology that I've used is the classic journalist method. find an interesting question, dig around, worry it a bit like a dog, sort of worrying something. See what comes out of it, dig up more facts, and at the end of it all, to try and make sense of these facts. And I submit that this is really it's really useful for people, for professional epidemiologists, for professional historians, also to have an outsider looking in. And because we look at things differently, we see things that you might not miss, you see things that I would miss. And so I'm really happy to be here and hope we will have some sort of a dialogue on what we're doing. This book actually started, innocently enough, as an attempt to understand one of the most ambitious acts that modern medical science is capable of. And what is that? That is eradicating a disease. And what is eradicating? Eradicating is permanently removing a disease from planet Earth. And how you do it? How do you do it? By driving to extinction the pathogen that causes a disease. And if you think about it, this is both ambitious, it is also audacious. Human beings, we have driven many things to extinction. Unknowingly most of the time, knowingly sometimes. But here, when you try to eradicate a disease, what you're trying to do is drive a microbe to extinction. In the case of polio, what you're trying to do is drive a strip of RNA into extinction. It's one of the smallest viruses known to man, and you're trying to drive it to extinction. And the success of eradication is to ensure that there's not a single exemplar of this virus left on Earth in its natural state. You might have them in labs and so on and so forth. And I found that fascinating. I mean, it is the equivalent of a moonshot. It's probably harder than a moonshot. I mean, just think about and it tells us a lot about human beings and the different ways we think of tackling disease, and also our belief in science. So all of these things intrigue me a lot. But once I started digging into this a bit, new questions kept cropping up. And the first one, of course, is why is the polio program so long overdue? It was launched in 1988, and by the year 2000, polio ought to have been eradicated. It was launched in 1988 by the World Health Assembly as a gift, and this is the wording of the resolution, a gift from the 20th century to the 21st century. We will remove smallpox, had already been eradicated, and the promise was that we pledged to the new century that there will be one more disease that has been eradicated. We are now in the second half of 2018, and actually we are, I think, a long, long way still from getting the job done. You have cases in Afghanistan and Pakistan which have never managed to interrupt polio. Polio has been interrupted 99% of the world, but in 2 countries it has not been interrupted. And remember, the success of eradication is not even a single example of the virus should be in its wild state, in its natural state, right? So that's not been happening. And more worrying, you have having cases of polio caused by mutated transmitting forms of the polio vaccine itself, cropping up in Nigeria, in the Democratic Republic of Congo, in Papua New Guinea, in Somalia. And in fact, now the cases of vaccine-derived polio are greater than the number of wild polio viruses cases. So I think this is really worrying, and I mean, David really is the expert on this. I'm the epidemiologist, so I will leave him perhaps to talk more about it. But the polio program itself is, as ever, absolutely optimistic. And the message is that 99%, the incidence of polio has been reduced by 99% from the time the program was launched. And that is absolutely true. I think there were roughly 300,000, 350,000 cases of polio in 1988. Now it's down to a handful of figures. But this 99% figure has been true for the last almost 10 years now. And the last big breakthrough was 2011 when India was declared polio-free. Since then, nothing is going on. These same two countries have never interrupted transmission, and at the same time, vaccine-derived polio cases are repeatedly popping up in areas that were once thought to be polio-free. So it's hard to say. I mean, whether one should be optimistic or pessimistic, but this is the way things are. So these were some of the questions that kept cropping up. But all of the questions that were swirling in my head about the polio program were actually encapsulated when I was traveling in northern Nigeria in December in 2012, the second half of 2012. And I was traveling with UNICEF. UNICEF and WHO are the partners the two main partners in the polio program, and the UNICEF is in charge of communication. So I was traveling with UNICEF communication teams, and we were in Kano in northern Nigeria. And one morning we drove to this village called Marke, M-A-R-K-A. And why? Because there were a large number of people who were refusing vaccine. And we went to one person's house. It was a farmer. It was called Sabu. And mud hut, we were all sitting on the floor. And you had the UNICEF people saying, you know, you need to do this, you need to protect your children, etc., etc. And finally he said, yes, okay, I'll do it. Right? All these foreigners are coming, they come in the big SUVs, natural courtesy, if nothing, all right, I will do it. But later, I was sitting with him and suddenly he exploded. He said, polio, polio, polio. Why polio? When my child has a fever, I need to find what the nearest public health center is 10 miles down the road, 10 kilometers down the road. I need to go to the main road. I need to hitch a lift, or I need to find a bus, or I need somebody to take me there. When I get there, there are no medicines. Why are people focused? And here for polio, people are coming every other day, right? And saying, have these polio drops, have these polio drops. Kids were dying of other things. Malaria, measles, diarrheal diseases. These were the real killers of children. But from the point of view of the public and for people in these areas, all the emphasis was on polio. And this didn't make sense. Why polio, polio, polio? And because it didn't make sense, it gave rise to, it's fertile ground really for various rumors to start spreading. So in Nigeria, and the same thing happened in Pakistan, you had preachers saying that, this polio, all these polio drops, this is the West's revenge for 9/11, right? They don't care about your children, right? But they want to make sure that your children are sterile. This drives them impotent. And so you had all of these rumors going, and so it was a huge issue. I think the polio program had tackling all of this, and so on, and so forth. But that's really not, my book deals with all of this, and that whole geostrategic, geopolitical issues, how the polio program got ensnared in the search for bin Laden, and the consequences of that, and so on and so forth. But there's just one question that I want to talk to, because I think that's what's more relevant today for you, especially for an audience that is interested in the history of medicine. How exactly did the decision by the World Health Assembly to eradicate polio come about? One level, it's as clear as daylight. 1988, the World Health Assembly voted to try and eradicate polio by the year 2000. At another level, it is really mysterious. The Director General of the WHO at that time was Haftan Malha, right? Who's probably one of the most visionary, charismatic leaders that I think the World Health Organization has had. And during his 3 terms in office, he had made sort of his banner, if you will, the goal of primary health care. Right? And it was during his time that the Alma Ata Declaration, primary health care, health for all by the year 2000. These were the, the big programs that the WHO was pushing at that time. Mahler was completely opposed to disease eradication programs. Smallpox actually was eradicated when Mahler, during his term, and he told many people at the time and in public statements as well, saying this is the last time, smallpox eradication is the last time that the WHO would ever devote its resources to a single disease eradication program. His philosophy was completely different. That same money, he felt, was much better spent by building up health systems, especially at the village level. He also firmly believed that health agendas, and by health agenda I mean the decision on which diseases ought to be tackled first, was something that really should be determined at the levels of communities, and not by big organizations sitting in Geneva and New York and so on. And for him, eradication programs represented everything, a lot that was wrong with healthcare. And his whole vision was community-led healthcare, primary healthcare, strengthening health systems. You can argue that it was utopian, and many did argue, but this was what, this was the WHO's banner during his 3 decades in office. And yet, in 1988, May of 1988, barely 3 weeks before he retired, in his last speech to the World Health Assembly, and ironically, this was a speech that was meant to commemorate the 10th anniversary of the Alma Ata Declaration. Like, we're at the 40th anniversary now, a couple of months about that. So at the time he was retiring, it was the 10th anniversary, and his speech was devoted really to what needed to be done in terms of bringing the goals of the Alma Ata Declaration to fruition. But suddenly he declared, and I quote from what he said, he looked at the World Health Assembly, at the members, and said, "What about having the guts to eradicate poliomyelitis from spaceship Earth by the year 2000? I think we should. I think it is doable. There is no excuse for not trying." And this seems to have been, if you read Mahler's speeches, is very much him. What about having the guts to do this? We need to do this. It should be done. So one of his last acts in office was to launch an eradication program, the kind of program that he had sort of spent most of the last 15 years fighting against. How did that happen? Why did that happen? It's hard to say because Mahler himself passed away in December in 2016. And I tried many times to get in touch with him, but he was not responding by that stage, or he didn't want to respond. But if you go through the documentation of the World Health Assembly, the 41st World Health Assembly, it was quite clear that this was a last-minute thing, right? Normally, before any major initiative, the executive board of the WHO, which is the WHO's main governing body, it's a small group of countries, they discuss everything first. And usually at the beginning of the year, they have a meeting, resolutions are proposed, discussed. The WHO Secretariat prepares a report, including the budgetary implications, and there's a fairly, serious discussion before anything reaches the members of the World Health Assembly. Right? In this case, there was nothing. It was not even on the agenda initially for the assembly. But Mahler's speech triggered this wave of activity. Here was his beloved leader, right? In his last speech says, do this, people did it. And so the Secretariat brought this draft resolution. If you look through the records, there's very little discussion. It was introduced by Canada, and people generally, in one of the committees, and everybody said this is a good thing, and that was it, right? So one of the most consequential decisions that the World Health Organization has taken was actually done pretty hastily, right? It was also a really low-key resolution. If you read it today, all it says that countries are invited to formulate and consider plans for vaccination coverage in order to make this happen. And I'd like you to compare this with all the activity that preceded the resolution to eradicate smallpox. That went on, I think, from 1953 or 1955 until 1958. The discussions went on. It came twice at least to the World Health Assembly. It was debated. It was sort of sent back to the drawing board. It came back. It was 5 years of activity at least before that happened. This was done almost instantly. And I think the contrast is really telling. Mahler had sort of launched this movement, if you will, or this call, and then he retired. And nothing very much happened after that, because the WHO department which was in charge of eradication was the EPI, that is the Expanded Program on Immunization. And they were not particularly keen on having this polio eradication program. And even in smallpox, I think within the WHO Secretariat, there's always been quite a lot of opposition, I think, to these sort of vertical, single disease focused programs. So the EPI and even the draft resolution made it quite clear that polio eradication was not to be an aim in itself. It was meant to be a means to achieve a wider goal, and that goal was to achieve the targets of the expanded program of immunization, which the WHO had launched about 10 years earlier, and the goal of which was to ensure that by 1990, every child was immunized against diphtheria, pertussis, or whooping cough, and tetanus. And polio was seen as this way to, get governments a little bit enthusiastic. Polio was meant to be the sort of a banner, like a sail, and the wind hitting these sails would push the entire boat to shore. That was the way it was looked at. The question is, I think the intriguing thing is, what made Mahler change his mind? And the only explanation I've been able to find was a meeting that was held in March that year at the Task Force for Child Protection in France, in Talloires. And this meeting, the Task Force for Child Protection it is a coalition of groups, including UNICEF, the World Bank, the Rockefeller Foundation, and WHO, which had as its aim pushing and promoting the universal immunization of children against vaccine-preventable diseases. Polio found mention in the final resolution of that. And Jim Grant, the head of UNICEF, Grant was, like Mahler, an extremely charismatic figure. And both of them, and because WHO and UNICEF worked together in so many programs, they worked together, but there was some slight tension between them. Grant was very, I think, taken up with the idea that the way to push this universal immunization boat to shore finally was to have this one banner disease, which would make people enthusiastic about it. And maybe Mahler as well thought this would be a good idea. But I think this is one of the most dramatic changes that you can see, and a change that there's no paper trail to explain how this change happened. Now, I want to come back now to my original question. Why is the polio program overdue? I think there are many reasons, everything from conflicts, the vaccine itself, which has not been behaving and did not behave in tropical areas which had the biggest burden of disease in the same way that it behaved in temperate areas or in Latin America. But I think one clear thing that does come out is that the decision to eradicate was hastily taken. There was no prior thought as to how much it should cost, which vaccine to be used. That came about a year later. People were just, do it, go and do it, without any roadmap. There was no discussion. Do countries have enough infrastructure to carry out this? And they didn't. Many countries could not even do this. And I think I'm going to stop now. I'm running out of time. But I think there's one of the issues that the WHO at that time really acted in haste. And I think what we need to make sure is that the repenting, which has been going on for some time, comes to an end, and that polio is finally eradicated. Okay, thank you very much, Lucia.
Thanks very much, Sanjoy, and Alex for having invited me, and thanks, Thomas, for having documented this very important program. And what Thomas did is led us to this discussion, which is polio eradication, the long end game. Actually, it should be called polio eradication, the longer than expected end game, because it was known that eradication programs many times have long end games. Smallpox eradication had a longer end game than was anticipated. But polio especially has had a much longer anticipated, longer than expected end game. And this is what Thomas talked about, was the resolution. And it says that smallpox eradication should be pursued in ways which strengthen, which give wind to that sail, the development of the expanded program on immunization. Now, the expanded program on immunization was 10 years old at that time. It had been developed because the world saw the power of vaccines in smallpox eradication. There were actually 2.7 million deaths in 1969 when smallpox eradication was finally increased in full force. And that's a lot of deaths. That's even more deaths than are occurring today from many of the diseases together, such as AIDS and TB and malaria together. So it was a terrible number of deaths which were occurring. And the development community decided that the expanded program on immunization would make sure that all vaccines, including polio, got to people. So then when this resolution came along, it sort of threatened the expanded program on immunization. And so in the resolution, it said it should be pursued in ways to strengthen this integrated immunization program. Well, there was a scientific basis for eradication. There was no reservoir in nature for this virus. It only lives in humans. It's easy to administer. Vaccine was available, this oral polio vaccine. There are 3 types of polio, type 1, type 2, and type 3. And the oral polio vaccine included all 3 types of virus, but it was an attenuated virus, a virus which caused no disease but did cause an immune reaction and protection. Industrialized countries had already used this vaccine to get rid of polio, so it was gone from industrialized countries. And there was strong global advocacy with Rotary International. And I would say that probably what really happened with the Director General of WHO was just before that World Health Assembly in 1988, when the resolution was passed, Rotary got to him. Because how many of you are Rotarians? Are there any of you who are Rotarians? Well, Rotary International, as you know, is a service club. And some of the Rotary groups from the US went to the Philippines back in the mid-1980s for an exchange program, and they saw that there were children paralyzed from polio, which had been gone from the US for almost 20 years. And so they became great advocates for getting rid of polio, and they actually formed initially partnerships with the Philippines and American clubs where they actually went over, American Rotarians, and helped in the vaccination programs. So they were a great advocate, and it was they who really pulled together a partnership of UNICEF, WHO, CDC from Atlanta, the Center for Disease Control, and Rotary International as the initial partners. So I would think, Thomas, it was probably Rotary that got to the Director General just before the World Health Assembly and convinced him that this was an important thing to do. But there was one problem in polio eradication. Whereas in smallpox eradication, every infection looked the same. You could tell when everybody was infected because they had the same look. They had these terrible pocks all over their body. In polio, for every child that was paralyzed by polio, there were 600 to 1,000 children who were infected who could transmit the disease to others and who showed no signs whatsoever. So it was a very difficult disease to eradicate, but it was undertaken despite that one word of caution. And there were three strategies that were developed. The first was routine immunization, and there's Kofi Annan, who was really an advocate for this program, as was WHO, trying to get everyone to make sure that children were vaccinated. But it was a very difficult thing to do because in some parts of the world, Africa, Eastern Mediterranean region, and Southeast Asia region of WHO, routine immunizations were not very strong. And so you can see that in order to get rid of polio, you had to increase to what's called herd immunity, which was about 90 to 95% of children vaccinated. So in Africa, you only had half that number vaccinated. So the program was up against great challenges if it was to work only within routine immunization programs which weren't getting to children. So the second activity in the program, in addition to routine immunization, was surveillance, making sure that every polio virus was identified. And this is a very important polio surveillance system around the world, with the pyramids representing national laboratories that isolate the polio virus from specimens, stool specimens from children with flaccid paralysis. Flaccid paralysis is like that Raggedy Andy doll. It's just flaccidness caused by polio. The green are regional laboratories which take the viruses from the national laboratories, process them, and send them on to the starred laboratories where there's genetic analysis and genetic sequencing done. Now that sequencing is very important because it helps in the eradication to understand how rapidly eradication is occurring. What you see in 2008 is a long string of different families of the polio virus. In 2009, you see that some of those families of polio have disappeared, and by 2010, most of them had disappeared. So by genetic analysis, looking at different families of virus, you can see what happens, because type 1 virus has many subfamilies, and type 2 has many subfamilies, as does type 3. These subfamilies are caused by mutation, and the polio virus mutates at a steady rate as it transmits through humans, so it's very easy not only to see what those mutations are, but to trace it back by backlogging to see where the virus might have originated. Very complicated, but very modern, cutting-edge technology. And it's so technologically helpful that you can see here in Pakistan in 2009 and 2010, they were actually able to find cases of polio in 2010 that could be linked back to cases in 2009 genetically. So what that means is that you could go back to the place where this virus was thought to originate and make sure that, that indeed the virus had been eradicated or eliminated from that area. This is only possible because the genetic sequences of polio are shared worldwide. They're in a global database that you can go into and compare your virus, the virus that you've isolated, to viruses that were occurring around the world. An important issue in polio, because if that sharing had not been possible, this program would not have been possible. But it's not only that they're looking for the polio virus in humans, in their waste materials, they're also looking now in sewage. And this is Mumbai with open sewage systems, where they continuously are looking for polio virus. And before Mumbai had gotten rid of polio, they were able to find polio 1 in red, polio 3 in blue, in the sewage system in Mumbai. You can also see that they found what's called VDPVs, which are vaccine-derived polio that we'll talk about, in that sewage, as well as just vaccine virus, because the vaccine virus is a living virus. It was also in the sewage. So a very important system of surveillance. So the first strategy was routine immunization, second strategy surveillance, and the third strategy was national immunization campaigns. Now these were meant to increase protection among children in places like Africa, where 49% were only reached by routine vaccination programs. And so polio eradication added campaigns as the third strategy, door-to-door vaccination of children in order to get immunity levels high enough to stop polio from transmitting. So the three strategies: routine immunizations, surveillance, and campaigns. But in 2001, 1 year after that target of 2000 was missed, there was polio identified in Hispaniola, which is Haiti and Dominican Republic, the island on which they're found. And polio had actually been gone from the Americas for 10 years. And all of a sudden in 2001, there was again polio in this island of Hispaniola. It was found that this polio was being caused by something which had not been expected at the time polio eradication was announced. It was a circulating vaccine-derived poliovirus, and Thomas talked a little bit about those. Those are viruses which are genetically different from the virus that's found in the polio vaccine, and they're different by greater than 1% in that genetic sequence, if any of you can picture a sequence of a genetic sequence. So these were actually viruses that came from the vaccine virus, but had mutated in such a way that they caused polio themselves. And this has become one of the major issues in polio eradication. And this shows you data from 2000, when vaccine-derived polio viruses were first identified, 2000-2001, in Hispaniola, all the way through to 2018. And if you focus on this, at the top you'll see in red C VDPV type 1, that's type 1 virus. Underneath it is type 2, underneath it is type 3. And if you look at the column just before the green rows begin, you'll see most recent collection date of other sources, human. You'll see that August of 2018, and August down below of 2018, they found both type 1 and type 2 circulating vaccine-derived polio viruses. And in addition, in the environmental, which is green, you'll see that there have been these vaccine-derived polio viruses identified as well. These are the same as a polio virus as far as humans are concerned. They cause paralysis, and they spread from human to human. Now, the eradication program was, first of all, to get rid of wild polio virus, and there's been great progress, as Thomas said, in that, and you can see that the virus only remains in Afghanistan and Pakistan. Nigeria has not been reporting, but Nigeria has a very poor surveillance system in the north of the country because of influence from the rebel groups in that area, Boko Haram, which has interfered with the surveillance activities. So it's not clear whether polio is gone from northern Nigeria or not. But it's clearly not gone from Pakistan and Afghanistan, where wild virus is still being found this year, 14 wild viruses in Afghanistan. And that means there are at least 1,400 people infected, or 14,000 rather, people infected with the polio virus, and in Pakistan, 4. In addition, in the environment in Pakistan, they're still finding polio virus, and the red indicates polio virus in the sewerage systems in various cities: Lahore, Multan, Rawalpindi, Karachi, Peshawar, and Quetta. So you can see the two, Peshawar and Quetta, are very important. They're still transmitting polio virus, and these are areas close to the rebel-held areas in Afghanistan. So that was one of the issues that first came in a challenge to polio eradication, is the vaccine-derived polio viruses and the still visible wild polio viruses. But there's a second challenge, and Thomas also spoke about this. But we'll start with 1988, when polio eradication began, because it was 1,000 children being paralyzed each year from polio in 125 countries. And there was really inequitable access to polio vaccine. But by 2003, there were less than 1,000 children paralyzed the entire year, from 1,000 a day to less than 1,000 in a year, and polio was only present in 6 countries. But even more importantly, there was equitable access to polio vaccine. Now, those 6 countries that still had polio because certain regions in those countries had very poor routine immunization services, and they just couldn't top up their immunity by campaigns and get rid of polio. But one of those viruses, type 2, had disappeared, even though they weren't getting good high coverage of polio, in 1999, and that virus has been certified as having been eradicated, the wild type 2 polio virus. But there still is circulating vaccine-derived polio virus type 2. But the wild virus was gone in 1999. Now, in 2003, the governor of Kano State in northern Nigeria said that polio vaccination was damaging young girls, as Thomas said, because of exploitative actions of Western nations towards developing countries. He was claiming that he had read on the web, which was true, he had read it, that polio vaccines sterilized young girls when they were vaccinated. And he saw this as a Western plot being run through the UN agencies, because he felt that the UN agencies were also being controlled by Western countries. And as a result, polio spread from Nigeria all the way across through Muslim and Islamic trade and religious pilgrimage groups all the way into Indonesia. So countries that had been polio-free became infected again. Now, it was very hard to get polio activities restarted in northern Nigeria, just to show you some of the challenges. WHO was considered part of the problem, but WHO has laboratories which work with it around the world, and two of those laboratories in South Africa and India approached the government of Nigeria and said, we will test your vaccine to see whether or not there are impurities in it which might be causing sterility in young girls. The vaccine was sent from Nigeria to these laboratories with pediatricians from Nigeria. They came back. The pediatricians presented the results, which showed no impurities in the vaccine, but the National Vaccine Expert Group said, no, that's not enough. We don't believe the results. So the next step was to take some political actions to go to the Islamic conferences, which is now called the Islamic Union, and they actually took into their head of state meeting in 2003 for the first time a health issue. And that was that polio was spreading throughout Muslim countries and that they needed to stop it. So they passed a resolution which is political will to do something about this. And you can see they called for political and financial support from member states to finish eradication. They continued to rediscuss this in meetings in 2004 and 2007 and 2005, but this by itself did not increase the commitment of the governor of northern Nigeria states to begin vaccination. They did not begin to vaccinate again. Then religious leaders were called in. There were fatwas made by many religious leaders, and actually Sikh Sese, who's in this picture, came over from Senegal to show that vaccination was safe. He brought with him his family, his grandchildren, and he vaccinated those grandchildren in a public ceremony in northern Nigeria to show that it was safe. That didn't do the job. In addition, then, WHO called an expert group to review whether or not there should be any travel restrictions, because polio could be carried by pilgrims back and forth. And so they recommended that they recommended some measures to prevent the spread of polio by recommending that people coming from Nigeria be vaccinated before they leave the country, in order to make sure that they were vaccinated and wouldn't spread the virus. This was taken up by the Nigerian government and Saudi Arabia, and Saudi Arabia required that all pilgrims have vaccination. And in addition, in northern Nigeria, you can see here there was vaccination of pilgrims before they traveled. It was thought that this might set an example for the governor, and he would stop his accusations. It didn't work. They continued to get booster vaccinations, the pilgrims, before they left. When they got to Saudi Arabia, they were vaccinated again, but the governor would not rescind his feelings. Finally, in WHO, there was a resolution, and this shows you in 2008 a resolution after many other resolutions, which accused Nigeria publicly of not having done enough to stop polio spread. And as a result, this went in the papers in Nigeria, and it was very important in all the newspapers that this was making the country look very poor publicly and in face of others. And so the president of Nigeria, said that we will do everything humanly possible to ensure that polio is finally eradicated. Now, Nigeria did everything they could after that. The governor rescinded finally his statement, and vaccination began, but as Thomas said, even as late as 2008, it was still very difficult to get people to vaccinate because of fear that that vaccination was sterilizing young girls. So that was two issues that occurred, challenges to eradication. One, vaccine-derived polio virus, still a challenge. Two, northern Nigeria, still in many ways a challenge because now rebel control of that part is not permitting polio surveillance. And the third challenge was a vaccine that wasn't working. And this shows you that vaccine, the oral vaccine being used in India. And what you see here are 90% on this graph, 90% of the children who had polio. Among those 90% children, you can see that 27%, because 10% had fewer than 3 doses of vaccine, and that means they would have been susceptible to polio. But the 4 to 6 dose, the 7 to 9 dose, and the greater than 10 dose children should have been protected. Yet among the children with polio, 36% had had greater than 10 doses of vaccine. There was something wrong in India. So a search in the literature actually showed the answer. This was a study done by Jacob John at the Vellore Medical Center back in 1976, at the time that even before polio eradication began. And what he showed is that this vaccine, which had polio virus type 1, type 2, type 3, was not working well for type 1 and type 2, but type 3, after 3 doses of vaccine, 96% of children were protected. You can see in the middle, 96% were protected after 3 doses. That's the explanation of why polio disappeared in 1999 already, because type 2, the virus in type 2 was stronger than the other 2 viruses and able to cause immunity. Type 1 and type 3 could not function properly when they were mixed in that vaccine, and so there was a separation of those vaccines, of those viruses, into what's called monovalent polio vaccine. So there was a monovalent polio vaccine 1 and monovalent polio vaccine 3 that were developed with funding from the Gates Foundation. So MOPV1 was type 1 virus, MOPV was type 3, MOPV type 3, and then MOPV type 2 was not made because it was already gone. It was eradicated. So this vaccine, when it was developed, showed that even after just 1 dose, 61% would be immune as opposed to 34% when the vaccine viruses were mixed together. So this is type 1 vaccines, type 1 and type 3, and they're now being used, but there's still a problem because they're causing vaccine-derived polio virus to be developed. There are some other issues that are making the endgame long as well, and that is that there's known polio virus in laboratories around the world. In fact, there are 94 laboratories that still have wild polio virus in their laboratories. There are many vaccine laboratories which have the Sabin, which is the polio vaccine virus, in their laboratories, and they also are laboratories that have collections of stool specimens that have been collected while polio was still circulating, which might have either vaccine or wild virus in them. So there's a lot of virus that's still out there, and that must all be consolidated. And this is the beginning to show you where those viruses are being consolidated and hopefully destroyed so that eventually polio will be eradicated. But the polio endgame has been slowed by vaccine-derived polio, and as you can see here, we now have wild polio, which is red, occurring in Afghanistan and Pakistan. And if you look over at Papua New Guinea, you'll see what's vaccine-derived polio 1, which should be black, but it's yellow on this, or orange on this. And then you see in Africa type 2 vaccine-derived polio and type 3 vaccine-derived polio. So we have a world where vaccine-derived polio is equally as important as wild polio virus, and the end game is very difficult. The end game is also very costly. This is what remains to be done. Interruption of wild polio virus, complete the introduction of an inactivated killed polio vaccine so you can get rid of this oral vaccine, which is causing vaccine-derived polio. You must make sure that all those viruses that are in laboratories are locked up or destroyed, and there's such an investment that's gone into polio that there needs to be a legacy from that in other disease control programs. So what does polio cost? Well, up to 2013, the program cost about 11 billion US dollars. And if you look at what it will have cost from 2013 to 2018, it's 5.5 billion more, and it will not end this year. It will go on. So there will be a need for much more funding. Fortunately, Bill Gates has stepped in, is funding a lot of this program because he sees this as a very important program. If this fails, it will be a very great discouragement to the public health community, and other programs may not take off. But there's one last sobering issue about polio eradication, and that is that even after wild polio virus is gone and vaccine-derived polio virus is gone and all the virus in laboratories has been locked up or destroyed, there will still be a risk because the polio virus has actually been synthesized in a laboratory way back in 1991 just using the genetic sequence, and that virus is now a risk to polio eradication as well, because any rogue scientist that would like to could get the genetic sequence and construct a new virus. So polio has had many challenges, and the final challenge is when will eradication finally be completed, and will the disease stay eradicated? So thanks very much, Joy.
So Professor Heyman has to rush to another meeting, but perhaps we can just direct for a couple of minutes questions to David, and then we're going to hang on to Thomas and not let him escape for a little while. So,
okay, thank you very much, David and Thomas. Thomas, you started off by saying that Kafka Mahler was very against eradication programs, and of course he did then move to this. More recently, we've seen the arrival of other eradication or elimination programs, most notably malaria, but I think there's been talk about, if I'm not mistaken, hepatitis C, even TB, potentially with new tools coming on stream. Would you like to comment on where we're going with these, and also the fact that that also seems to be in a context of decreased willingness of governments, both donor governments and governments with less financial resources, to invest in public health and move away from that, and all of the talk about universal health coverage, primary health care Mark II. There seems to be a lot of tensions around at the moment, and maybe a not complete consensus on where we might be going with this. I just wonder your views on that.
Yeah. Well, you know, there was an attempt to eradicate malaria before smallpox eradication back in the 50s and 60s. And that program succeeded in eliminating malaria from certain places. Sri Lanka, India almost eliminated it. But then there was a resistance that developed in the mosquito to the insecticide that was being used. And for many reasons, the program was abandoned. Then, in the early 2000s, it was not WHO that announced malaria eradication. It was Bill Gates who announced it. Bill Gates committed to eradicating malaria, and that's what's been the power behind the eradication of malaria. And now there are many new tools which are being used, many new devices, and in some places, again, malaria is being eliminated. And so there's a great effort on using the tools we have today to get rid of malaria rather than waiting for a vaccine which may or may not come. And this is very important because in smallpox eradication, smallpox was declared eradicated in 1981 using a vaccine which itself caused neurological damage. In 1969, there were actually 9 children in the U.S. who had neurological damage from the vaccine. It was a very unsafe vaccine. But that vaccine was used and eradicated smallpox, and in 1981, HIV was first identified. In 1985, a military recruit in the U.S. was vaccinated with the smallpox vaccine used in eradication, and he was HIV positive, not known to be HIV positive, and it was an AIDS-defining event. We know today that you could not have eradicated smallpox if it had continued into the 1980s, because it would be impossible to determine who was HIV infected, who wasn't, and how to use that vaccine safely. So the lesson is, use the tools you have today in order that you can do the best you can. And that's why Gates announced malaria eradication. He feels the tools are there. He's developing new tools with a whole group of people, and he felt that malaria should be tackled, and it has been.
Can I just add to that for a minute? Actually, the disease that is eradicable, that will happen once polio does happen, if it does happen, is going to be measles. And even at the time when the decision to eradicate polio was happening, there was this toss-up between, because both of them biologically are very similar. These are viruses that only affect human beings. You've got a vaccine for them. So really, measles is what is happening next. You have these regional elimination programs, but people are going a lot more slowly now, rather than saying we will eradicate by such and such a date. It's happening much, much more slowly, much more systematically, and I think that probably is the way to go about it. Sort of go step by step, no deadlines, but just keep working at it.
That's right, and there is another eradication program on guinea worm,
That's right, yeah.
which is a worm in Africa, which will be eradicated soon as well. The issue, though, is go slow, as you say, Thomas, and make sure that you can do the job, that it's feasible to do it. There's also been an animal disease that's been eradicated called rinderpest. And so gradually we're getting control of these animals. I was very pleased to speak with you. I was very pleased to speak with my colleague Thomas. I must go, though, because I'm due at a meeting at WHO tomorrow on polio eradication endgame. And so I'll be going over there, and I hope that we can bring back good news. So thanks.
Thank you.
Thank you, David.
Thank you.
So more. Sumit?
Yeah.
So, I think while you were talking about, you mentioned Armada, so I think in 2018 it's primarily starting from this. So what I am kind of thinking is like, so we're talking of end games, but it's fascinating hearing the story and the different cracks through which it enters your armor, like sewage, which is open defecation, religious concerns in Kano and perceptions and things like that. So these all are common enemies or common gaps. So you started with health system strengthening and primary health care and things like that. But I would like you to comment is like, so we are now having again these neglected tropical diseases like even Ebola and things like dengue, which is in South Asia, is like almost every day the cases are coming up. So on one hand, we are talking of elimination, containment, eradication. On the other hand, and talking of the resources that goes into this, we still have these very much vertical programs. But the gaps which have been talked about here are common programs. So thinking of a global health policy and where we should investing our energies and our efforts, communications, don't you think we need to give a much more sharper call on kind of forgetting these elimination things, but rather tackle the common enemies together, and there lies our greater chance of success, other than, so every day we'll still have, somebody says that Ebola is off, so DRC is safe. Then again, next year we again have something in DRC. So
by common enemy, do you mean basic issues like water, sanitation?
Yeah, I mean the ones which were pointing out, like the transmission, like surveillance.
Right.
I mean the ones which David has been mentioning.
I get your point. So what you're basically saying, why don't we spend, and I think that's a very good point, we should be spending money and getting these basic building blocks of health systems in place. And I couldn't agree with you more. Why does that not happen? Most countries, especially poorer countries in the world, require external resources to do this. And to be honest, it's not easy to get donors to cough up money for things like health system strengthening, better surveillance. But if you go to a donor and say, we want to get rid of this disease in 10 years' time, this is how much it's going to cost, people will give. People get excited. This is the whole idea of a banner disease. How do you get people excited? Governments excited about this. Money, donors excited about this. Healthcare workers excited about this. And this is really a paradox. The real stuff that needs to be done is nuts and bolts things. Surveillance, water and sanitation, having adequate healthcare workers, having enough nurses, enough doctors, primary care healthcare centers. But it's really hard for somehow, the will to do this seems to be very weak. And the will, I think, is at the level of governments, even at the level of societies. It's just not there. So I don't know, maybe you require a process. I think, first of all, you need to start dialogues like this going, talk to people, have discussions, saying that shouldn't we really be focusing, shouldn't we be putting our money on these basic things? And once we get that foundation right, then it's a lot easier to, solve other problems, hit individual diseases, and so on. What we've been trying to do so far, and polio is a classic example of this, is without a proper foundation, we're trying to build this really fancy house. To achieve one of the most ambitious things that medical science can achieve, which is eliminate a strip of a sequence of RNA without a proper foundation. We need to go back to the basics. I would agree with you. The question then is, how do you get governments excited about this? How do you get donors, foreign aid agencies excited about this? And that really is the issue.
Or like just, if I can, one more small thing is like, so in India we have this good example, I recall of the Pulse Polio campaign.
Mm-hmm.
Now, don't you think it is also important to see that those lessons of this intensive week-long campaign, we have seen how it has gone across India. But I'm afraid that some of those lessons of that intensive mission mode has been somewhat lost on the general health workers. So how do you think that momentum, even when a disease is gone, that momentum could be sustained in the system? And I'm talking of a communications guy to you. How do you think that could be more internalized?
And the point that he's making was, there was this enormous surge of enthusiasm to eradicate polio in India. And he had these intensive programs with healthcare workers. Week after week, they would go knock on doors, they would give medicine, they did meticulously. And finally, polio was eradicated from India. The thing is, that kind of intense work, that level of work, it's very hard to sustain. The Indian polio program was a great success, but it was, in a sense, sucking out health workers from every other program.
Even other people.
Yeah. So if it's an emergency, if you know that within a year we can finish this, then you can throw everything at it. But year 1, year 2, year 3, year 4, year 5, you cannot. It's like running this continuous marathon. You're trying to run a marathon of 23 miles, 40 kilometers, and suddenly you say, I'm sorry, now it's 50 kilometers, now it's 60 kilometers. You cannot sustain it. And so this is an issue for eradication programs, and this is one reason why it's hard to get this kind of enthusiasm.
Thank you. My name is Alexis Gilbert. I'm a public health doctor in Leeds and also do some work with UNICEF. Mm-hmm. So a couple of questions. I really enjoyed the talk, first off. One was you talked about the polio eradication campaign, initially being the idea of being the wind in the sails for that kind of more wider EPI and even maybe even primary care in the long distance. How much do you think there was a missed opportunity over the last 30 years in actually making that a reality?
I think it was a massive, massive missed opportunity. It's complex, and I've tried to really oversimplify because, we just had a limited amount of time. It was a huge missed opportunity. And why was it a missed opportunity? And it goes back actually to the problems that you also raised. EPI, routine immunization, implies you need to build health systems, brick by brick by brick. Polio eradication was a program that was tacked onto this with a definite deadline. By 2000, we need to finish. And when that wasn't happening, basically the polio program broke free, because you had donors, governments who were giving money to the polio program saying, hey, what's going on, guys? So for the polio program, in a sense, to survive, it had to break free. But there was a price to pay. And the price to pay was that routine immunization was neglected. And because routine immunization was neglected, polio has a chance to come back now. And so, yes, it was a massive missed opportunity. So I don't know why did this happen, because it's I mean, you really, it's I don't know, square pegs, round holes, things that don't really fit very well together, and with different agendas. And here's the thing, you know, eradication programs are intense, time-bound programs, because they're intense, you know, with this really ambitious target, this moonshot, if you will. Routine immunization health is a much longer thing. And if you put both together, it really doesn't work. So here, I mean, to take this analogy one step further, probably taking a little bit too far, what happened is that the sail just snapped off, right? And sort of flew into the sky, and the big ship of routine immunization is adrift somewhere on the high seas.
Just a really quick follow-up, if no one else go on. How much do you think we should be better at making the economic case?
Sorry,
how much do you think we should be better at making the economic case for this sort of activity? 'Cause I think very often we talk about it in health outcomes, but we don't ever talk about the externalities to a nation of the investment in this sort of thing.
So this was one of the justifications for polio eradication, was that the money that you would save over generations to come, right down to the last human being, whenever, and as long as the human race existed, was enormous. So there was this payoff in terms of thing. On the other hand, I mean, clearly you do need an economic matrix, some sort of economic decision-making tool, but it's also hard, because when you deal with human lives and when you're dealing with human outcomes, and there's certain things it's hard to measure, right? What is the cost of polio immunization versus, I mean, this is the whole dilemma, really. You immunize a child against polio, it's protected from polio, but 2 years later, it gets this severe malaria and then dies, right? So how do you balance these two things, right? So you've protected this child from polio. So as far as the polio program is concerned, and if you look at the economics of the polio programs, perfect, right? But if you look at the poor child, it's not a very happy outcome at all. So I don't know. I'm sure I'm not a health economist once more, and I'm sure that this is not. I'm stating something that's really obvious. And there are decision-making tools which factor all of these things in, and so on and so forth. It's a useful decision-making tool, but at the end of the day, you are dealing with human life, and so we need to, to really, to use this tool wisely, I think, as well.
Not. I'd like to thank you for joining us.
Not at all. My pleasure. Thank you.
I think,
Thank you so much. Thank you very much.
You kept people attentive and interested.
Thank you very much. It was lovely. It's been lovely being here. It's been a great audience. Thank you.